Growth assessment. Nutrition plays a major role in both the physical and intellectual development of children. Monitoring growth and development is a cornerstone of pediatric care. Healthy infants and children typically follow a predictable pattern of development, which allows growth to serve as a sensitive marker for health and nutritional status. Growth can be affected by a variety of conditions, and alterations in growth can be the first sign of a pathologic condition. Marked deviations from a normal growth pattern, particularly during early life, have also been associated with an increased risk of comorbidities later in life. Delayed growth in childhood has been associated with decreased adult height and altered body composition, including increased abdominal fat mass, in adulthood. Further, a substantial body of research has demonstrated that malnutrition can lead to abnormal brain development, including tissue damage, disordered differentiation of neural cells, reduction in synapses and synaptic neurotransmitters, and delayed myelination. These can lead to lasting cognitive impairment, affecting attention, visual, auditory, memory, and executive function, and interfering with a child's school performance and potential for achievement. Clinical evaluation of a child's growth should focus on key historical features, as well as accurate measurement of all growth parameters. The history should include a thorough dietary history, weight, length, and head circumference at birth, prenatal history, past medical and family history, and a complete review of systems for evidence of systemic disease. Body weight, length or height, head circumference, and weight, for length or body mass index, BMI, for age are easily measured or calculated and can be compared with population standards using growth charts. Appendix A. Pediatric growth can be divided into 3 periods: infancy, childhood, and adolescence. Infant growth. The intrauterine environment and maternal nutrition are primarily reflected in the growth parameters at birth and during the first few months of life, after which genetic and environmental factors exhibit a stronger influence. Many infants will significantly change growth percentiles, and hence, their corresponding z-scores, for weight and length during the first 2 years of life, but then usually follow their established growth trajectory after age 2. Term neonates can lose up to 10% of their birth weight during the first few days of life and should get back to their birth weight by days 10-14. After return to birth weight, infants typically follow an established pattern of weight gain during the first year of life. Expected weight gain during infancy is approximately 30 g-day from age 0 to 3 months, 20 g-day for ages 3 to 6 months, and 10 g-day for ages 6 to 12 months. Infants should roughly double their birth weight by 4 months of age and triple their birth weight by 12 months of age. Weight gain slows after the infant's first birthday. Normal linear growth in infants is approximately 10 inches, 25 centimeters during the first year of life. Feeding methods can impact the weight gain patterns seen in infants. Breastfed infants typically gain weight more rapidly during the first 3-4 months of life when compared to formula-fed infants, and relatively slowly thereafter. By age 1-2 years, the weights of breastfed and formula-fed infants are similar. It is important to correct growth parameters for gestational age in preterm infants. However, there is limited consensus on the duration of catch-up growth in premature infants and how long to correct for gestational age when interpreting growth. The World Health Organization (WHO) suggests correction of weight, height, and head circumference until age 2-3 years for children born prematurely. Chapter 12. Childhood growth. Children gain approximately 2 kg year between age 2 years and puberty. They typically gain 4 inches, 10 centimeters, in length height during the second year of life, 3 inches, 7.5 centimeters during the third year of life, and 2 inches, 5 centimeters, year between age 4 years and puberty. With increasing height and slowed weight gain, toddlers and preschoolers grow taller and leaner. Of note, growth during this period is pulsatile, consisting of periods of rapid growth separated by periods of minimal growth. There is also normal deceleration of height velocity before the pubertal growth spurt during adolescence. Adolescent growth. Puberty refers to the physical changes that occur during adolescence, including growth in stature and development of secondary sexual characteristics. The latter occurs in a series of events that also follows a predictable pattern, with some individual variation in sequence and timing of onset. Between 8 and 13 years in girls and 9.5 and 14 years in boys. Sexual maturation can happen gradually or with several changes at once. Tanner staging is a sexual maturity rating system used to define physical measures of sexual development, including breast changes in females, genital changes in males, and pubic hair changes in both females and males. Tanner staging is commonly used to define the pre or peripubertal stage of a child at a single point in time. Appendix B. In boys, the first change is testicular development followed by penile growth and pubic hair development. In girls, the first change is breast development followed by the appearance of pubic hair, which is then followed by menarche. Approximately 20% of adult height accrual occurs during puberty, though the pattern of height accrual can be highly variable. It can be steady growth or periods of rapid growth interspersed with periods of slow growth. The typical pubertal growth pattern involves a phase of acceleration, followed by a phase of deceleration, and ending with the eventual cessation of growth with the epiphyseal growth plate closure. The timing of the growth spurt varies by sex, occurring 2 years earlier on average in females than in males, and is impacted by sexual development. Therefore, a child's Tanner staging can provide clues regarding the timing of an expected acceleration in growth. Peak height velocity is reached in boys between Tanner stages 4 and 5, while in girls it is highest between stages 3 and 4 and is followed by menarche. Menarche can occur between 10 and 16.5 years. After menarche, the average height gain is about 2.75 inches, 7 centimeters, and can be even greater for girls who menstruate on the early side of normal. Growth typically ceases about 2 years after menarche. Early onset of puberty, and subsequent earlier peak height velocity, can lead to transient periods of tall stature when compared to same age peers, but is typically associated with reduced overall adult height accrual. The major sex differences in height are established during puberty, with a final average height difference of 4.9 inches, 12.5 cm between males and females in the general population. See Appendix B for more information about Tanner staging. Measurement of growth. Surveillance through regular measurements of growth is an important tool to monitor the health of children. While a normal growth pattern does not guarantee overall health, atypical growth can reflect nutritional insults and can be the presenting sign of systemic illness. Accurate measurements of growth are essential for growth assessment. Growth can be measured in 2 ways. 1. Current, attained growth relative to same age peers, and 2. Growth velocity, which reflects the change in a growth parameter over time. Weight should be obtained naked for infants less than 2 years of age, and with only light clothing without shoes for older children. Measurements should be repeated 2 to 3 times and used to calculate an average value. Tables 1 to 1.3. Whenever possible, subsequent weights should be measured using the same scale to improve accuracy. This measurement can be plotted on a standardized growth chart, Appendix A, as described below, to assess a child's weight relative to same age peers. Wheelchair scales can also be used for patients that are unable to stand unsupported. This can be done by recording the weight of the empty wheelchair followed by weighing the patient in the wheelchair. The difference between the weight of the patient in the wheelchair and the wheelchair alone is the patient's weight. For hospitalized patients, weight should be measured daily for preterm and term infants and at least weekly for older children. Patients with nutrition and growth concerns may require daily weights, including older children. For patients seen in the outpatient setting, weight should be measured minimally every 3 months for infants and yearly for children. More frequent weights may be needed in the outpatient setting as well for patients with nutrition and growth concerns. Length and height. Length, as opposed to a standing height, is used for children 2 years of age, 85 centimeters, and or unable to stand. Length can be obtained using an infant measuring board or measuring mat. Table 1.4, but should not be measured using a tape measure or by marking the infant's length on an exam table. Height, used for children 2 years of age, should be obtained with the child standing upright without shoes and looking straight ahead. Table 1.5, similar to weight. These measurements should be repeated 2 to 3 times and used to calculate an average and can be plotted on standardized growth charts to compare a child's height to same age peers. Appendix A. Height velocity demonstrates the rate of height accrual over time and requires a change in height over a period of at least 6 months to be calculated accurately. In certain patients, alternate measurements may be taken to estimate height as indicated. Tables 1.6 to 1.8. Serial measurements can be helpful in determining if a patient is demonstrating linear growth. These alternate height measurements should not be used to calculate BMI or ideal body weight, IBW, as they are only an estimate of actual height. In the hospital setting, length height should be measured weekly for preterm infants, monthly for term infants and younger children. and at least every 3 months for children 10 years and older. In the outpatient setting, length height should be measured every 3 months for children under 2 years of age and at least annually for older children. More frequent length height measurements may be necessary for patients with nutrition and growth concerns. Head circumference. Head circumference serves as a reflection of brain growth. It should be measured around the head parallel to the floor with the tape just above the eyebrows in front and around the most prominent portion of occiput. Table 1.9. Standardized head circumference charts can be used to assess a child's head circumference compared to the median for age and gender. Appendix A. Head circumference typically increases approximately 1 centimeter month during the first year of life, with the most rapid growth during the first 6 months of life. Most head growth is complete by 4 years of age. Head circumference should be measured for infants and children until 2 years of age, and in older children as needed. In the hospital setting, it should be measured monthly and at least every 3 months in the outpatient setting. More frequent measurements may be indicated in patients with nutrition and growth concerns. Body mass index. BMI. BMI is a measure of proportionality and demonstrates how well a child's weight and height correlate with each other. It is calculated using weight in kg and height in meters, using the following formula. BMI equals percent body weight. Height. 2. BMI can vary based on age, gender, and pubertal stage and is used as the clinical standard for diagnosing obesity in children 2 years of age and older. BMI is typically normal in children who have constitutional growth delay or familial short stature. A BMI less than the 5th percentile or greater than the 85th percentile may demonstrate that a child is underweight or overweight, respectively. Alternate height measurements should not be used to calculate BMI. Indices of body proportionality are valuable in the assessment of overall nutrition status, and the indices typically used are the ratio of weight to length, typically expressed as a percentile or a Z-score, and BMI. Traditionally, weight for length. Z-score is used in children under the age of 2 years and BMI for age. Z-score beyond that age. However, BMI for age. Z-scores are available in children under 2 and can be used, with the caveat that inaccuracy in length measurements, that are unfortunately common in infants, can change the BMI for age. Z-score more than it changes the weight for length. Z-score mid-upper arm circumference. MUOC. MUOC is an anthropometric measurement that measures both fat mass and fat-free mass. Measurements are compared to age and gender-based standards and reflected as a percentile or Z-score based on population norms. MUOC is a tool that predicts pediatric malnutrition due to undernutrition. MUOC measurement is an inexpensive procedure and requires minimal equipment. Table 1.10. In specific patient populations, where weight may be skewed by fluid retention, peritoneal dialysate, casts, or other medical devices, the use of MUOC is preferred over weight for length or BMI. MUOC should be frequently measured for infants and children that are at risk of malnutrition. Clinically significant changes in MUOC can often be noted on a monthly basis. Z-scores can be calculated for patients 6-60 months old using WHO reference data or reference tools such as PediTools.org. For patients 6 years and older, MUOC can be compared to normative data to determine percentiles or Z-scores. Appendix C. Additional growth measurements. Additional growth measurement techniques may be used in specific patient populations. They can be particularly helpful in determining the nutrition status of patients with fluid retention, patients with enlarged organs, i.e., liver failure, and patients with large tumors. Skin fold thickness. Skin fold thickness measures subcutaneous body fat and is an indicator of total body fat composition. Triceps skin fold, TSFT, measures subcutaneous fat on the limbs and subscapular skin fold. SSFT, measures subcutaneous fat on the body trunk. Tables 1.11 and 1.12. Skin fold thickness varies based on age and gender with assessment of measurement based on median and standard deviations of the population. TSFT measurement is the most common and correlates with estimates of total body fat in women and children, whereas SSFT is shown to be the best predictor of total body fat in men. TSFT and SSFT are not indicated as short-term measurements of fat stores. Skin fold thickness may not reflect total body fat stores and may not correlate with visceral fat deposits surrounding internal organs. Measurement of MUOC and skin fold thickness is